Hello everybody, I am Mauro Fradeani and would like to welcome you on this new topic, the prosthetic revolution, and how to optimize the aesthetic and function with a minimally invasive prosthetic procedure with the so-called MIPP procedure. First of all, we have to consider the initial situation of the patient, and today we are really working on many patients with a lot of wear. And if we can alter the vertical dimension of occlusion, if we can really reduce the thickness of restoration, all that in order to reduce the invasiveness of our treatment, to preserve enamel, and to really have a predictable bonding procedure. Let me introduce to you this difficult case. This young lady has a Sjögren syndrome, and practically, as you know, that is really a very critical situation because you have no saliva. So you can see the wear that the patient has by the erosion, attrition, abrasion. So we have really not so much to structure remain. What to do in this case? Maybe in the past we have used a lot of cases like that, some surgical cryo lengthening procedure, endodontic treatment, and post-encore. That was quite classic, a traditional way to do it. But today, what we really like to do is to put the patient in center relation position, increasing the vertical dimension in order to minimize really the invasiveness of our treatment, to be as less aggressive as possible. To test this new height between the two arches, we can have some mock-up that allow you to really certify that you can do it, at the same time to also show the patient how looks the aesthetic result that you can obtain at the end. What about the vertical dimension increase? If you look at this review article that was published in 2012 by Abduo, you can see that the conclusions are, whenever is indicated, you can increase the vertical dimension up to 5 mm anterior, and that has to be considered a safe and predictable procedure. Just in case you have some sign and symptoms like some speech problem or some tenderness and tension in the TMJ area, normally these kind of signs and symptoms are self-limiting and they resolve within 2 weeks. That's what this article shows, as many other articles. Now let me show you this picture. We are now in the posterior area. If you increase the vertical dimension on anterior area, you have a lot of space really to avoid to be aggressive on tooth preparation. You theoretically should not be able, you don't need to really prepare the teeth in this case on anteriors. What about posteriors? Of course, you have much less space on the last molar. And remember that normally what is requested by companies, by every book that you can read it, every brochure, the thickness on occlusal surface on the last molar will be normally 1.5 to 2 millimeters. In this case, if you look at the dotted black line underneath, you see that you remove all the enamel that is there, even in a case like this in which you have a perfect intact tooth. So really we are very aggressive with the normal tooth preparation modality, and that is normally needed on porcelain fused to metal and even in the all ceramic restoration when you select the bilayered solution, core plus layering ceramic over. So how to achieve the goal that to maintain tooth structure? First of all, you have to increase the vertical dimension of occlusion, as we said. Why? Because again, you create space even on posterior area where the space is very limited. So again, we have no problem on anterior because if we increase 3-4 millimeter, we have enough space for our restorations. But on posterior, maybe you have 1.5 millimeter if you increase 3 to 4 millimeter on anteriors. So at this point, you see already that increasing the vertical dimension, as you can see in your right part of the screen, you have the chance to really stay far away from the border. When you have an intact tooth with the intact enamel, you stay out from the border between dentin and enamel that is signed by the black dotted line. So that's interesting. So in this way, with the original video, and with increased video, is absolutely better because we really can save some tooth structure. That is a very important step, but has to be combined with the second step. And the second step is the reduced ceramic thickness. And now the question is, how can we reduce the ceramic thickness? Is it possible to do that? So, if you use a monolithic solution, you can really probably use an etchable ceramic. Why? Because if you have increased the vertical dimension, plus you have decreased the modality of tooth preparation, and not preparing 1.5 but 0.8, at this point, automatically, we can almost avoid to grind the teeth occlusally because you have already enough space. In this case, you preserve enamel. At this point, you can bond a monolithic etchable ceramic. That is the point. So, again, this is the border if you have increased the vertical dimension. But you go more up if you really create a kind of increasing vertical dimension plus reducing the preparation modality, reducing the need of occlusal reduction not to 1.5 but to 0.8 millimeter. So you can see at this point on your left side that you can also be out of the tooth. So it means that we don't prepare the tooth. Having increased the vertical dimension combined with the minimal invasiveness of your tooth preparation. Reduction will be practically very, very minimal. And that is, with increase of VDO, you have achieved the combination between increasing VDO, 0.8 millimeter for each arch, plus 0.8 for occlusal reduction. We really have the chance to really save the tooth structure as much as we could, almost nothing, almost no preparing. So now the chance is monolithic or bilayered. And at this point, as you can understand, posteriorly, we are really normally use the stain solution. It means the monolithic solution with reduced thickness, 0.5, 0.8 millimeter. In this case, using lithium disilicate, you can also have the chance to layer it anteriorly to optimize the aesthetic result, even though you can also use just the monolithic even on anteriors to really be sure 100% about the strength that you achieve at the end. So basically, anterior tooth preparation was really changed over years. In the 90s, maybe that was the normal preparation modality and thickness. But then we start to prepare less and less. And today, I can say, really minimize tooth preparation this way, just removing the undercuts and keeping as much enamel as possible. That's the point. Now going back to the case, you can see the preparation modalities and thickness. You can appreciate that we have, of course, added some composite on the dentinal area. Plus, you can see on the occlusal surface, the anatomy of the tooth is still there. We have saved the tooth structure. We have minimized the tooth preparation. And that's our preparation that I made more than 8 years ago. Today are also even more minimal. So, again, the second step and now the first step. In order to maintain tooth structure, that is still our goal, we have to preserve enamel. Because if you preserve enamel, you really can say you have created a very safe and predictable bonding procedure. Of course, at this point, having enamel underneath, we need to use an etchable ceramic that has to be etched with hydrofluoric acid and then to put silane and then to follow all the bonding procedure. So at the end, we have achieved this kind of result. Nice result in terms of aesthetics, but what we really need to know that we have monolithic material on posterior and a layered porcelain on the back side, on the vestibular area of the anterior in order to optimize the aesthetic result on the upper jaw and in the lower jaw. The final result is also highlighted by this picture. I'm not talking about the colored picture. I'm talking about the black and white picture that shows you that no one tooth was treated endodontically. And that is something that is really not usual to find, or at least it was not usual to find in the past. So that is the best result that you can achieve, helping the patient that is in difficult situation. Not just giving back to her an aesthetic result, but also to really create a biological integration on the pulp maintenance, but also on the gingiva outline. You can appreciate that now we have really achieved very nice result in terms of biological, functional, and aesthetic integration. We have the chance to see that we have achieved also the exclusion of posterior teeth through the anterior guidance, having really avoid any interference on posterior area. So is an overall integration through this kind of MIPP technique that I really consider a kind of a revolutionary approach on prosthodontics. I hope you enjoy this focus on, and I'm sure I will meet you again next.